Hi everyone, welcome to today's webinar on using human factors in hospital technology procurement. My name is Jason Thompson. I'm with the Canadian Patient Safety Institute, and thank you very much for joining us today. This is part of a series of calls that we have on human factors. We've had several so far, and if there's any that you've missed or are curious about, you can find them all on our website, patientsafetyinstitute.ca. This is also a series that's going to continue well into the new year, so you can watch for future calls coming in February, March, and April as well. This call, along with all of them in the series, will be recorded and posted online, so if there are any that you missed, you can always go back and check them out. For more information about CPSI or any of our offerings, you can visit our website, patientsafetyinstitute.ca. You can also sign up for our newsletter to stay on top of the latest information, or follow us on Twitter at patient_safety. At the conclusion of today's presentation, we'll have time for a Q&A, so I encourage everyone to use the chat box to submit your questions. We'll gather them, and we'll have a chance to ask them of our speaker once she has completed her presentation. Without further ado, we will introduce our speaker, and she's the only one we've got going today. Her name is Dr. Svetlana Tanava, and she specializes in the application of human factors engineering to the development and evolution of human-centered technology and organizational processes in clinical environments. She has published extensively in a number of journals and conferences on topics of healthcare human factors and patient safety. In addition, she is the author of a book on the management of surgical coordination processes, an editor of a book series on human factors research in healthcare, and a co-author of a book chapter on technology-based approaches to mental health care. Currently, she is the Senior Human Factors Specialist at Healthcare Human Factors, University Health Network in Toronto. Svetlana holds a doctorate in engineering, specializing in healthcare human factors, a master's in computer science, specializing in cognitive engineering and human-computer interaction, as well as a bachelor's degree in psychology. With that said, I'll now turn it over to her. Svetlana, the floor is yours.
Thank you for that introduction, Jason. Hi, everyone. Good morning, good afternoon, depending on where you are located. My name is Svetlana Tanava. I'm part of the Healthcare Human Factors group in Toronto. We're located at the University Health Network. We are a large group of human factors experts who work not only within UHN, but also with a lot of organizations across Canada as well as globally. So today I'm going to talk to you about using human factors in hospital technology procurement, but before I go specifically into this topic, I wanted to give us a refresher of what human factors really is. So there is a lot of misconceptions about human factors. A lot of people believe it's all about psychology or all about human error or only about usability testing. And human factors is all of those and so much more. So human factors is the application of the science of human behavior to the design of systems. What that means is that we take what we know about human performance, human cognition, human limitations, and we apply to that knowledge to the design of systems so we can engineer for human efficiency and effectiveness to accommodate the limits of the human user. In doing so, we look at the entire environment in which humans work, function. We look at the technology, the physical layout of spaces, processes, and workflows, and any of the tools used within that environment. So what we're seeing on this graph kind of shows what's happened over time with technology versus humans. So the capabilities of technology have increased exponentially over time and continue increasing. But the capabilities of humans have remained relatively the same. And this creates a gap between what we as humans can do and what our limitations are and the advances of technology. Nevertheless, in working environments and in healthcare, it is humans who have to operate the technology, manage it, and be responsible for any mishaps. So the underlying philosophy of human factors is to bridge that gap, to design systems that adapt to the nature of humans and our limitations, and not the other way around. And in doing so, by bridging the gap between human capability and the demands of the task, in healthcare specifically, what we aim to achieve is improve patient safety, minimize use errors, reduce the need for training and the training time, increase efficiency, and accelerate adoption. So yes, we are interested in ensuring the design of systems and technology and environments is easy and safe to use. But to get there, what we need to do is understand the environment in which technology is being used. And human factors engineering does this through a systematic approach that is very rigorous. And unfortunately, not all technology manufacturers or process designers take such a rigorous approach. And what ends up happening when this approach is not being followed is that when you put a new product in an existing environment, you find that there's a lot of reluctance to use that product because it does not support users' needs well. But in the case of healthcare, what's even more important is we see a lot of negative outcomes in terms of patient care, patient safety, because of things that happen unexpectedly when you introduce a new product into an existing environment. And so a lot of these human factors related issues manifest themselves into adverse events. And if we look at the statistics of the preventable patient deaths, it's staggering. So these numbers are recent numbers from the States, where the estimate is between 200,000 and 400,000 people die every year due to preventable medical error. If we only look at the lower limit, this is equivalent to 3 jumbo jets with 300 people on board crashing every day and killing everyone on board. Now, if we see this in the news happening with the airline industry, we probably would never get on an airplane again. Yet, because we don't have those cumulative numbers popping up in the news every day, we keep going to hospitals, not realizing that, there's a lot of issues that we still need to solve in terms of patient safety. And in Canada, the numbers of estimated preventable medical error associated deaths is between 17,000 and 23,000, which may look better, but considering the population size in Canada, it's really the patient safety rate is no better than what we saw in the States. So over the last 15, 20 years, with the publication of such statistics, there's been growing recognition of the critical importance of human factors. And one outcome of that recognition is that several years ago, the Food and Drug Administration in the States introduced a new regulation that requires any new medical device to go through a rigorous evaluation process, which includes human factors evaluation. And this is a step in the right direction to start thinking about safety and best fit into existing environments. But unfortunately, it's only a first step, and it only covers medical devices. So there's a lot of more technology being used in hospitals beyond devices, such as software applications, information systems, and other health products, and none of those are regulated. So there's no requirement for them to do any human factors evaluation. There's also no regulation over how products are being chosen for procurement or how a chosen product is being implemented within existing processes. So what ends up happening is that a lot of times we see products being implemented in highly complex work environments without anticipation of their profound impact on work processes, human capabilities, or possible conflicts with existing technology or policies. So the question is, if you're a purchasing organization, how do you go about ensuring you buy the right product, not only from a functionality and cost perspective, but also a product that will be safe to use, will integrate well without introducing or reallocating inefficiencies and risks. So how do we go about doing that? As you might be well aware, purchasing decision for a healthcare organization is a very high-risk decision because, one, it's a huge investment that would have significant impact that could last decades. Healthcare organizations do not buy new infusion pump or new electronic health record every year or even every 5 years. And these technologies are very expensive, and they touch a lot of people, they touch a lot of staff, and they affect efficiency, safety. In the Canadian context, we're also spending taxpayer dollars. So we're looking at a decision that has very long-term consequences and implications for patient safety, efficiency, and staff experience. And purchasing a product that does not support well existing care practices or does not easily integrate with existing processes can contribute to increased need for training, quality improvement efforts, inefficiencies, and patient safety risk. So the opportunity that we're looking at here is to recognize that in this day and age in healthcare environments, the volume of technology is increasing. The complexity of technology is also increasing. We're looking at such systems, for example, as electronic medical records that touch so many different user groups. We're thinking physicians, nurses, pharmacists, administrative staff, as well as patients. But even within those user groups, a single product such as an electronic medical record has to meet the needs of so many different clinical areas with different demands, different environments. It could be the emergency room, palliative care units, rehab units, ICUs, many different areas with different environments and different demands. And even within those areas, there's so many different tasks that such products need to support: imaging, documentation, medication ordering, scheduling, communication, decision support. So highly complex products nowadays. And we need to also recognize that when we are looking to purchase a product, we can't look at it in isolation, because once we bring it into the environment, there's going to be a lot of interdependency of technologies with what we already have in the hospital. Also nowadays, clinical staff is busier than ever, which has implications as to how much cognitive attention they can devote to managing a product that might not be very user-friendly. And we are increasingly concerned with errors associated with technology use. So there is a huge risk associated with the purchase of new products. Now, if we look at the traditional procurement process, there's, specifically within the healthcare setting, there's some pitfalls, such that some of the most important factors and what's mostly the criteria for picking a product nowadays is based on cost and functionality. There's also lack of frontline user involvement in the procurement decision, mostly on the management level. And it's very much dependent on vendor demos. The problem with vendor demos, they can be very biasing depending on how thick the demo is made, how well the vendor organizes the demo, how well the vendor is liked. They also do not represent a realistic environment of how a given product will be used. So usually during a demo, the system or product is not going to be configured exactly the way they will be used in the intended setting. And when clinicians have an opportunity to sit down and try out the product during a demo, there's also a vendor representative who's really hand-holding that person and telling them what button to push, what click to make in order to accomplish a task. And in real life, nobody's going to be sitting next to a clinician telling them where to click and what to do. However, it does bias perceptions, because when somebody's helping you, everything seems very easy. So people are often wowed during demos by products that are not necessarily very user-friendly. Also, early on, financial decisions are made, and they often carry as much weight as technical and clinical review. So what can human factors contribute to improve procurement for hospitals. The goal is to provide objective evidence to inform the procurement decision. And part of that objective evidence is to identify the risk associated with using a particular product for the given organization within their processes, within their existing environment, and to use that information and the identified risk to negotiate needed customizations with the vendor. Also, obviously, to inform the decision which vendor to go with. Also, that objective evidence is used to inform the implementation strategy, the training strategy, and to ensure best fit to the needs of the specific users and healthcare environment. So how do we do that? We use a methodology that calls for the intended users to perform representative and high-risk tasks. It's a methodology called usability testing or high-fidelity simulations, where we're looking to identify potential usability issues through testing with real users. So we invite the potential real users from that particular organization that is looking to purchase a product. So if we continue with the example of electronic medical records, we would invite physicians, nurses, pharmacists, admin staff, and patients. And we recreate a realistic environment within a usability lab. When I say a realistic environment, I mean all of the nitty-gritty details that you would not see in a vendor demo, such as ambient noise, which is very common in clinical environments, affects how people function and how people think. We introduce interruptions if needed, which means we have actors playing other nurses or maybe playing a physician coming into the unit to conduct rounds. We might have some planted risks within the test proceedings to see if a product facilitates identification of risks that currently exist in the environment. So we have those representative users perform representative tasks with all of the contender products that are shortlisted, and we provide them with realistic training that is standardized, that is reflective of the kind of training that they would normally get if they were purchasing that product. We record all of the test proceedings, video and audio recordings through cameras that are mounted on the ceiling in the lab, so very unobtrusive. And we also collect subjective data through semi-structured debrief interviews as well as questionnaires. What's also really important to note is that we recognize that there might be effects of learning and fatigue when you're testing several products with the same participants, so we counterbalance those effects by switching the order of products tested with each participant, as well as changing up the order of scenarios. So let's look at what are the necessary steps to allow for such a human factors evaluation to happen within the regular procurement process. There is certainly some investment with some added work in order to achieve the results that we're aiming for. During the product identification phase, basically we're looking to engage human factors expertise as well as frontline staff at the outset as part of the multidisciplinary team. And human factors would work together with clinicians to identify user requirements, user needs from a human factors perspective. The way that this is done is through observations and user research in order to identify, again, from a human factors perspective, what are the challenges in the given environment and how do we want a product to solve those challenges. And once the user requirements are derived, they're included as part of the RFP. And the RFP also includes a description of the human factors evaluation process that products would have to undergo. Once the organization shortlists several products, then there is some effort required on the part of vendors to help support the usability testing. So what we're aiming for is for people who will come for the usability test to see similar menus, drug libraries, and options enabled and disabled as they would should they purchase the product. So that means that the vendors need to configure their demo versions such that they can support the usability testing, which would be reflective of this specific organization's implementation. So the vendor would create those versions of their demo and provide those. They would also provide HumanFACTORS experts with the training required to learn to use the system, because during usability testing, it is the HumanFACTORS people who would train participants. We're trying to avoid bias, but because vendors are aware of the tasks and scenarios that we're going to test, so we want to avoid a situation where they're training to the test. We want to provide a standardized test that is reflective of actual training people will receive in real life. Once we're ready for testing, we move on to the product evaluation phase. Before we conduct the actual usability test, we also perform what's known as an expert review or heuristic evaluation, where we identify potential usability issues based on design principles. And those are issues that can be explored during the usability testing in terms of how often do they occur, do people detect the issues, what is the severity in terms of impact on patient safety, and so on. So it just helps us to anticipate some issues that we want to verify during usability testing, how they would manifest themselves. And once the usability test is conducted, then the process continues as normal with technical evaluation, financial review, in-use trials, and a final decision is being made. So now, just to give you an idea of how this works out in practice, I'm going to provide you with a case study on infusion pumps. Basically, we had one organization looking to purchase new pumps for their neonatal ICU and adult acute care environments. They were looking to purchase both patient-controlled analgesia pumps as well as large volume infusion pumps. We conducted usability studies with the pumps that were shortlisted from each vendor. In this presentation, for time and for simplicity purposes, I want to focus on the learnings just from the large volume infusion pumps, where we had 2 pumps shortlisted. And a little bit as a context to this, there was at the outset of this project a very strong preference for pump A because it was essentially a newer model of the pump that those units were currently using. That's how we started off this project. In terms of stakeholders, HumanFACTORS was involved from the beginning. There was also clinical representation, including frontline staff. Management was involved in infection control, transportation folks, supply and purchasing, and biomedical engineering. So what is the process that HumanFACTORS followed in order to get to usability testing? We started off by identifying what are the tasks and scenarios that we want to test for. Again, they have to be representative, essential tasks, and also high-risk tasks. So we engaged with clinicians via a survey to identify from all of the possible tasks that we could test, what are the critical tasks that we really need to prioritize. Once we had that list, we needed to also understand what is the intended environment of use for those products. So we conducted a lot of observations in the units that were looking to purchase these products to build context for how we're going to create the simulations. All the nitty-gritty details, what is the level of noise, how much interruptions, what is the patient population, what is the physical layout, all of those are not things that that translate from one organization to the next for the same unit. So because we're looking at this particular organization, this particular unit, we wanted to have high fidelity simulation representative of what's happening on the unit. Taking pictures and then recreating everything within the lab environment. Once we had the tasks and the context, we drafted up scenarios for testing Clinicians validated those scenarios and provided us with example patient cases. We also conducted the expert review or heuristic evaluation, which helped us refine the scenarios such that we can account for any anticipated use risks with the products. Then we conducted pilot sessions to refine the testing protocol, and then finally the usability test. So we had a total of 8 end users participate in the evaluation of the large volume infusion category. Those were 4 NICU nurses and 4 adult acute care nurses. And each participant received training on each pump immediately before working with that pump. And then they were asked to perform the basic essential tasks such as setting up an infusion on the pump, modifying infusion settings and hitting a soft limit or hitting a hard limit, resolving an occlusion alarm and an empty reservoir alarm. After running through the scenarios with each device, the participants filled out questionnaires and a final debrief captured their overall preference. So basically we had the subjective data and the objective data, and again, to balance the effects of fatigue and learning, each participant tested the products in a different order, and also scenarios where applicable, where the order and sequence was changed between participants. So the types of things that we were looking at in the data is, were people able to complete tasks accurately without error? And if they did commit errors, what kind of errors were those? How frequently did those errors happen? What was their impact and severity in terms of patient safety? We looked at task efficiency in terms of how long does it take to complete tasks with each product. Also, were people able to independently complete tasks, or were they asking for help because they couldn't proceed independently? And we collected user feedback and preferences. Once we had identified all of the different issues, we prioritized them based on their relevance to usability and patient safety. So we deemed high priority issues those that have direct patient safety implications and or prevent users from completing tasks. So an example of that would be, and this is an actual example, it's confusion between primary and secondary infusion programming screens. So participants were asked to titrate a secondary infusion, and there were instances where someone was changing the secondary infusion, or they were thinking they were changing the secondary infusion, but they were actually titrating the primary. And this could have implications for the patient outcomes, and it is reflective of how visible or not critical information is on the pump screen. Medium issues were those that have indirect patient safety impact and or could result in considerable user frustration and inefficiencies. So an example of a medium priority issue would be on one of the pumps, there was an alarm that triggered too quickly during the programming of an infusion. So when someone would actually take the time to think through what they're doing, make sure they're doing it correctly, this alarm would keep popping up and interrupting them and distracting them. This was also an issue during the double-checking process, as people commented that the alarm was annoying and interfered with their concentration. And low priority issues were not relevant to patient safety so much, but they were issues that affect general usability and the user's overall impression of the system. So an example of that would be one of the pumps, the way that the mechanism to attach it to a pole made the pump very unstable. So when you push buttons, it wasn't steady. So people ended up having to hold the pump with one hand in order to be able to push buttons on the pump. So what did we find? Both pumps had critical issues. So there was no perfect product, but pump A had a higher number of issues in each category, high, medium, and low priority issues. We also looked at the number of times that people were not able to complete tasks independently and ask for help, And again, Pump A had a lot more requests for guidance. Also in terms of time to complete scenarios, Pump A slightly longer time than Pump B. In terms of the subjective data in the questionnaires, people from the NICU setting felt that Pump B was the safest and easiest to use after they had a chance to perform those tasks on the pump. And people from the adult acute care environment, similarly, majority of them favored Pump B. And now I want to remind you that at the outset of this project, there was actually a strong preference for Pump A. After people had a chance to really use those pumps in a realistic setting and environment, those perceptions quickly changed. So we calculated for procurement purposes in order to inform the procurement decision. We calculated a score out of 20 where we gave the most weight to usability issues, but also there was the factor of task efficiency and subjective ratings calculated into the score. So Pump B received a higher score based on this criteria of, so the score was 18.99 out of 20. And yeah, overall Pump B had fewer usability issues, better task efficiency, and higher subjective ratings. So likely with the traditional procurement process, the decision may have very easily gone into choosing Pump A because of the cost, functionality aspect, and the initial preference that everyone had as it being the newer model of the existing pump they had on the units. But the findings from the HumanFACTORS evaluation show that it wasn't the better choice, even though both products were not perfect. One of them, Pump B, stood out as safer and more efficient. And also the insights from the HumanFACTORS evaluation helped to identify the specific needs around training and rollout strategies and implementation strategies that would help address the shortfalls of Pump B. So this was just one example of how HumanFACTORS work can inform procurement decision for a healthcare organization in terms of a medical device. Of course, that kind of work is not limited to infusion pumps. There's a lot more than even just technology that HumanFACTORS can support. So I have just several examples of other procurement projects that we have supported. So electronic medical records, an organization was looking to invest in a new electronic medical records system, and this is a huge investment. It's an investment in the amount of close to $1 billion, so huge, huge, huge. We conducted usability testing, and what we found is that there's so many use-related risks with the existing systems that were shortlisted by the organization that it really didn't justify the investment from what they currently had. It wasn't a big leap to how much things would improve to justify the investment. So the decision was made actually to postpone purchase until better technology is available on the market, and we're hoping that with next generations this will improve. Another example of procurement support that we have done in the past is on anesthesia gas machines. So an organization was looking to purchase those. They had shortlisted 4 products. We tested them. 2 products stood out as being significantly easier to use with minimal patient safety implications. So the organization looked into those 2 products, decided on one of them, and it was based on how well it would fit their current process and environment. Another example is procurement of a surgical instrument management system. So we evaluated 2 systems for an organization, and one of them, during usability testing, demonstrated a significantly lesser number of critical patient safety and usability issues. And that organization used the insights from usability testing to require certain customizations to the product from the vendors, to inform the training requirements, mitigation and implementation strategy, and basically to prevent any potential use safety risks. So we're in a hospital. We have some overhead noise happening right now. But anyway, so the next example is actually a little bit different. It's not technology, and it is how human factors can help after a product has been purchased. So in one organization we worked with, they had started a new contract with a vendor for supply of heparinized syringes, and those are used for arterial blood gas sampling, which is drawing blood. And those syringes are very similar, as you can see from the picture, to regular syringes. So this organization experienced near miss in their neonatal ICU, where a nurse was preparing a feed for a pre-AMI baby. They feed them with syringes. So she was preparing the feed, and just about as she was getting ready to feed the baby, she realized that she was holding a syringe that contains heparin. And this amount of heparin could kill a pre-AMI baby. So there was concern that there will be ongoing confusion and patient safety issues given this near miss. So the organization turned to the vendor with their concerns. And of course, the vendor said that there's no problem with the design of their syringe. They have a label, if you can see it on the picture, with very small font that says contains heparin, and everything is fine. However, the organization continued being concerned, and they contacted us asking us to evaluate how much of a risk it is. What is it that they're looking at? So we conducted high-fidelity simulations of basically the journey of the syringe from supply stocking to feed preparation and administration with all kinds of potential people who would have access and touch this type of syringe. And what we found during simulations is that hardly anybody was able to distinguish the heparinized syringe from the regular syringe. So if you see, the only difference is the small font on the syringes and the plunger color. However, so one syringe has clear plunger, the other one has a white plunger. However, they're both packaged in white packaging, which really removes the opportunity to distinguish the plunger color. Syringes are often labeled with labels on top of the syringe, which would cover the actual writing on the syringe that says contains heparin. So yeah, we found that throughout the journey of the syringe, none of the people that have access to that syringe are able to distinguish it. So the risk is really high for more near misses or adverse events to happen. And then that organization used that data to present to the vendor. At that point, the vendor decided that they are willing to break the contract and not take the risk of any adverse events associated with this. So the benefits of using human factors in informed procurement is that there is objective evidence that an organization can use to inform the procurement decision. That evidence includes identification of risk, and this information can be used during negotiations to require from the vendor needed customizations. Also, by choosing the right fit, the right product for the specific environment, the likelihood of improved adoption is increased, improved efficiency, decreased need for training, and improved patient safety. So in the long run, the burden of quality improvement efforts is reduced, and the number of potential adverse events and litigation will be reduced. So in conclusion, we cannot assume that manufacturers test for safety. Some do, some don't, but even those who have a rigorous approach to evaluation with a human factors perspective in mind, there is no product that fits all. So just because one product works well for one organization doesn't mean the same product will work well within the environment of another organization. And simulation takes into consideration the complexity of real healthcare environments. And also simulation uncovers system issues that can be addressed through further simulation, basically designing mitigations to address risk. And this takes further simulation to refine those mitigations and to ensure that they will work. So how is this relevant to the current healthcare procurement landscape in Canada? A couple of years ago, the Ontario government announced that they're investing $20 million in health innovation, and one of the areas of focus is to shift to procurement practices that focus on outcomes such as fewer hospital readmissions and the long-term value of medical devices. Basically, they conducted a survey of healthcare organizations, and they found that procurement was perceived as a barrier due to too much focus on standardization, lack of freedom, etc. And these kinds of efforts are not unique to Ontario. There's similar initiatives throughout Canada in trying to promote innovation in healthcare procurement. Just very recently, there was another announcement that there is Experts Council working on a strategy for healthcare sector supply chain. And the aim is to develop a strategy that delivers a supply chain model for Ontario's healthcare that is seamless, innovative, integrated, and rooted in value-based procurement. So what is value-based procurement? On a high level, it's a process that creates healthcare value by focusing on the needs of end users, placing emphasis on the overall system value rather than cost, so moving away from cost considerations, and engaging a healthcare organization and a vendor in sort of a partnership of co-creating solutions to address challenges. So the overall goal is to support the attainment of better health outcomes, improve system performance, and patient experience. So it's a very good model to strive for, but it's a very general approach. The shortcoming is that it does not specifically account for the types of expertise required to address the system-level issues, system performance that they ultimately want to address, and the patient experience. In practice, the examples I've seen of value-based procurement carried out in healthcare, and they've experimented with that more for a longer time in Europe. It's just starting in Canada. But the examples I've seen, the way they carry this through is through clinician engagement in discussions, which is great. It's a step in the right direction. But in reality, to tease out issues such as process effects, reallocation of inefficiencies, and risks, you really need to have human factors and systems engineering expertise on the team to be able to address those, both as requirements and then to evaluate how a product really meets those requirements. And unfortunately, vendors do not offer such expertise. So the good news is that the Government of Canada is really looking into innovation approaches to procurement in healthcare, and it is the right time. They're pushing, there's different pockets of money to promote this kind of innovation. And it's really the time of a make or break deal to gather the right team when an organization is procuring to make sure that those value-based procurement approaches would be successful. Human factors would be essential in this quest that is now promoted as Canada's healthcare imperative. So this is it for my presentation. I'll be happy to take some questions now.
Thank you very much. I do believe we have quite a few questions, which is good because we have about 15 minutes left on the clock. So I'll just go through them as they came in, if you don't mind. The first one is, should the vendor be given realistic test conditions for the demos?
I think in order to strive for objectivity, it's better to have sort of a third party involved, Yes, for sure, vendor can have an opportunity to have a demo with realistic conditions, but from what we know, of course, vendors, they want to sell their products. So by putting the control into the vendor's hands, they can manipulate conditions. And unfortunately, from a clinician's perspective, it's easy to be wowed when you have that help of the vendor. But really, if we're serious about identifying risk for a given environment, we need to maintain that objectivity and have a third party involved.
Okay, the next question is, how do you do usability testing without actually having the product purchased? And in this case, the person is thinking of a current situation where all the interface work with their electronic health records has to be established prior to being able to see how the product works within the environment.
So this is the effort on the part of the vendor. So we give them the requirements for the usability test. We give them the tasks. We give them the patient profiles that we would require in order to be able to run the usability test. And it is an effort and investment on their part as participants in the RFP to do those customizations, to build those patient profiles, to allow us to have a realistic working functional product for the usability test. Okay,
this one might perhaps might conflict with something you said earlier, but one question is, should vendors be a part of the demo process, or do they skew the results?
So I don't see the vendor demos as producing results. They are an opportunity for people to touch and experience the product. But again, if we don't have the usability testing aspects, then the vendor demos do become very biasing based on how well those demos are organized. So if we think of it in that sense, then yes, it would skew the decisions based on how well they organize their demo, how slick it is, how well they perform in that sense. But yeah, in the general sense of results, they don't produce results, but they do bias people.
Okay, this next question is asking for your thoughts on a center of expertise which could perform human factor studies and then share the results with various groups. Do you think that form of centralized testing, if you will, would be valuable?
So in general, yes, it is valuable, and we have in the past, when we conduct this kind of work, we have shared our outcomes with the vendors, with other organizations. The only risk and caution with that is that, again, just because one product does not perform well or does perform well for a particular setting with a particular process in place and particular constraints within that process doesn't mean that this translates well into the next healthcare organization that might have a completely different process, completely different.
Okay, great. Next question is around group purchasing, and they give the example of MedBuy and Mohawk. So the use of group purchasing for equipment is increasing. However, what they're finding is that this is further removing hospitals from being able to provide input and inform the decision process. How can human factors be applied in these types of situations?
So we have actually in the past supported smaller scale group purchasing, 2 or 3 hospitals getting together, looking at different products. And the power of group purchasing is that now you're looking at an even bigger investment than a single hospital, so the vendors are interested from that point of view. And human factors can take into account constraints for the different hospitals and test for all of those. And we have in the past identified that, you know, based on 3 or 4 products that are shortlisted, one product will be better for the one hospital, another product will be better for the other hospital. But overall, a consideration for including human factors in those situations is that to really get useful results, you need to get into the nitty-gritty of each process, each environment, each organization.
Okay. The next question is whether there's a specific or standardized framework that you'd recommend be applied when assessing different tools, so whether it's hardware or software.
I would say that it really depends on the product. This is still, again, because we're facing a lot of challenges in healthcare procurement in general. That's why the government is promoting, experimenting with new models. So there is nothing that I would say currently would be a standardized framework to use. But we are in a moment of time where, in the near future we might get there. Because currently we are looking into how to improve procurement for healthcare organizations.
Okay. During the RFP process, what questions should people be asking the vendors related to human factors? Are there any recommendations there?
I think in order to, again, get unbiased information, probably the best questions to ask is, has the vendor applied any human factors, design principles, design activities, evaluations in the development of the design of their product, and what kind of testing, what kind of methodology have intended users been involved, because even sometimes vendors might have on staff their own human factors experts, but oftentimes they would use internal people to the company to sort of test their products, which is very biased and does not reflect how a product will be used outside of the manufacturer setting. So these are the types of questions, is to understand in detail how they went about the design of the product. So this gives you an initial indication as to the level of rigor, the level of depth in terms of human factors that they invested in the design.
All right. Next question is around perhaps a trend towards purchasing one electronic health record for all facilities in a specific region, or in some cases provinces. Did you have any thoughts on that?
So I understand the question. It's a difficult answer because, again, based on my knowledge of the landscape of electronic health records and medical records, the products are not good from a human factors perspective. There's a lot of inherent risk from a use safety perspective. So I would say once we have a good product, of course, because the scope of electronic health systems is so big, once we have a good product, yeah, sure, it would be great to have that everywhere. But until then, really we need to balance between the advantages of having everything electronic versus the risks that we're introducing through implementing a system that is not well designed from a human factors perspective. And we've seen a lot of resistance to adoption to electronic health records. We've seen a lot of adverse events as a result of use of electronic health records.
Okay, great. That's it for the questions that have come through. Thank you very much, Svetlana, for a great presentation and discussion afterwards. I think judging by the questions, the number of that came through, as well as the number of people who were commenting during the presentation looking for access to your slide deck, this was very well received. So a recording of this webinar, as well as the slides themselves, will be posted on our website in a few days. It'll be the same web page that you went to register for this. So if you've got that saved or bookmarked, or you can even just search for it on our website. Once again, visit our website, follow us on Twitter, watch for our newsletters. We'll have all the information about upcoming calls in the Human Factors series coming up shortly. And thank you very much for attending today.
And thanks everyone for tuning in.
Thank you. Have a good day. Bye.